Today's class is on anti-arrhythmic drugs. What do we mean by arrhythmia? Anyone? Arrhythmia माने कि arrhythmia is any abnormal deviation from the normal cardiac rate or rhythm. Now, anti-arrhythmic drugs are drugs used to prevent or treat irregularities in the cardiac rate or cardiac rhythm. Arrhythmias are the most important cause of sudden cardiac death. However, only few arrhythmia needs treatment with anti-arrhythmic drugs. Abnormal automaticity or impaired conduction or both underlies the mechanism of cardiac arrhythmia. There are different precipitating factors for arrhythmia that can include ischemia, electrolyte imbalance, pH imbalance, mechanical injury to the heart, stressing of heart due to heart failure, neurogenic cause, and it can be even drug induced. Even some anti-arrhythmic drugs may provoke the individual to arrhythmias. Now, this is a diagram of the heart showing the electrophysiological activity there. The SA node is on the right atrium, AV node, the bundle of His and the branches, the bundle of branches and the Purkinje fibers. Now, cardiac action potential. In the heart, generally two types of cells are there. One is contractility cells that help in the contraction of the heart, and the conducting cells that help in impulse generation and conduction, like SA node, AV node, bundle of His and the bundle branches. They have got more conducting cells. Now, in the contractile cells, the action potential, they have got four phases, as we know from the physiological classes. These are resting membrane potential 90 millivolt, minus 90 millivolt is the phase 4. Then, due to the opening of the sodium channel, after the membrane reaches the threshold, there is rapid opening of the sodium channels leading to phase 0. Then, due to the closing of the sodium channel, there is slight dip in the membrane potential, that is phase 1. Then happens, there is opening of the calcium channels, which is counteracted by the opening of the potassium channels, and so there is electroneutrality in the cardiac membrane potential, and that is phase 2. Then calcium channels start to stop and the potassium channels remain open. That leads to rapid repolarization. That is phase 4. Phase 3. That is phase 3. And then again the cardiac action potential reaches to the phase 4. This is a normal cardiac action potential for the contractile cells. Now, how it differs from the action potential of the conducting cells? Anyone? Difference between the action potential of the contractile cells and the conducting cells of the heart? There is a normal action potential of the contractile contractile cells, and even in the conducting cells, what happens? And why the phase 1 occurred here? Sorry, why the phase 0 occurred here? Because of which channel? Class 1 to first semester পড়ে এসছো কোন চ্যানেল দিয়ে phase 0 টা হয়? Opening of which channel? Sorry? No. It's because of the sodium channel. But in the conducting cells, number one thing, the phase 4 is like that. That means it spontaneously reaches to the threshold potential, unlike in the cardiac action potential of the contractile cells. Now, what happens? This occurs due to the opening of the various channels, sodium, potassium and calcium. Now then, due to the opening of the L-type calcium channel, there is phase 0. Then the calcium channel start to stop and rapid repolarization occurs. This is phase 3. There is no phase 1 or phase 2 in the action potential of the conducting cells. Then again it reaches the membrane, resting membrane potential, that is minus 60 millivolt, and then again it starts to depolarize. So here the action potential generation is spontaneous. So, but this rate of phase 4 depolarization is fastest in the SA node. So they are the natural pacemaker of the heart. And the pacemaker activity in the AV node, in the bundle of His and the Purkinje fibers are basically suppressed by the natural pacemaker of the heart, and hence they are called latent pacemaker. Now coming to the mechanism of cardiac arrhythmias, we can broadly classify the cardiac arrhythmia into two types: bradyarrhythmias and tachyarrhythmias. Bradyarrhythmias are where when the heart rate is lower than 60. The normal sinus rate is in between 60 to 100. When the heart rate is lower than 60, it is called bradyarrhythmia. When in arrhythmia the heart rate is more than 100, we call them tachyarrhythmias. To understand the action of anti-arrhythmic drugs, we should understand the pathophysiology or the mechanism behind the tachyarrhythmias. There are three mechanisms. There are three mechanisms to basically understand tachyarrhythmias. Number one is enhanced automaticity. Enhanced or ectopic pacemaker activity, or we say it enhanced automaticity. Now this rate of phase 4 depolarization, here basically the cardiac membrane becomes more permeable to the sodium ion, and hence the rate of phase 4 depolarization it increases, and the pacemaker activity or pacemaker discharge of the pacemakers increases. Now when the latent pacemakers like AV node, bundle of His and others, they discharge at a more rate compared to the SA node, then they may take up the activity of the pacemaker of the heart, and that results and the arrhythmia may occur, and hence enhanced cardiac automaticity. Then the second mechanism is triggered activity. Now triggered activity are also called after-depolarization. Now this occurs because of the abnormal permeability of the positive ions either in phase 2 or phase 3, phase 1, 2, 3. Now you see, this is a normal cardiac action potential. Now when an abnormal depolarization occurs in either the phase 1 or phase 2 or phase 3, there if it surpasses the threshold potential, then it can cause a bump in the cardiac action potential, and if it is enough to bypass the threshold potential, and another cardiac action potential can be seen. This is called after depolarization. It can be early after depolarization if it occurs either in the phase 1, phase 2 or phase 3, and it is called delayed after depolarization if it occurs in the phase 4. Examples of after depolarization, early after depolarization examples: delayed after depolarization is seen in digoxin toxicity. Now coming to the re-entry. In re-entry, basically we know the normal conducting tissues of the heart. The impulse arises from AV node, it passes to the SA node, it passes to the AV node, then bundle of his, bundle branches, and finally to Purkinje fibers. Now, when there is an accessory pathway or abnormal pathway that connects upper chamber of the heart to the lower chamber of the heart, then what happens? Then the impulse is generated in the AV node. Normally it goes to the SA node, it goes to the AV node, bundle of his, bundle of branches, Purkinje fibers. Then the impulse stop there and wait for another impulse to come from SA node. Now when there is an accessory pathway, now this impulse after reaching the Purkinje fibers can again go through the accessory pathway and reach the atrium. Now if SA node till then does not fire, then this impulse can activate the AV node and hence a circle is created. This is called re-entry. Similarly, if an accessory pathway is there, when the impulse reaches the AV node, there is an accessory pathway. Impulse can also go through the accessory pathway. Now what happens if the two pathway, one of the pathway is fast, that it conducts the impulses very fast, and another pathway conducts the impulse very slow. This fast pathway, they have got additional long action, long refractory period, and this slow pathway, if it has got short refractory period, then what happens? Impulse will travel first through the fast pathway because it is because the conduction here is very slow. It will conduct very fast. It will reach the downside of the circle or below the AV node. Now it can go either down via the bundle of his Purkinje fibers, or and additionally it goes up through the slow pathway. Now when meeting the upper current, it can cancel each other. But sometime if an ectopic beat arises, as already a current has passed through it due to long refractory period, the current is not able to pass through it. Then current enters the slow tract, reaches the downside of the re-entry circle, and then again when reaches the fast pathway, this pathway have become, the refractory period is over here and it can very well pass through the fast pathway, and hence a re-entry mechanism established, and this is responsible for the WPW syndrome. So re-entry due primarily to abnormality of conduction, and impulse may recirculate in the heart and cause repetitive activation without the need for any new impulse generation. Now these are important cardiac arrhythmias: extrasystole, paroxysmal supraventricular tachycardia, atrial flutter fibrillation, ventricular tachycardia, torsades de pointes, ventricular fibrillation, atrioventricular block, and these are some of the ECG graphs. Now coming to classification of anti-arrhythmic drugs. Anti-arrhythmic drugs have been classified by Vaughan, William and Singh into 4 classes: class 1, class 2, class 3 and class 4, according to their action on the electrophysiology of the heart or electrochemical of the property of the heart. Now coming to the class 1 drugs, they are basically sodium channel blockers. These are again divided into class 1A, class 1B and class 1C. Class 1A include Quinidine, Procainamide, Disopyramide, Lidocaine. Class 1B include Lidocaine, Mexiletine. Class 1C include Propafenone and Flecainide. Now coming to the class 1A drug, before that, this is the diagram of the sodium channel existing in 3 different states. Number 1 is closed state, where the channel is closed and any sodium channel can pass through it when comes in contact. Now, this is an open state. In response to a nerve impulse, the sodium channel opens up and sodium can pass through it. And this is an inactivated state, where the sodium channel will not open up even in presence of the electrical impulse. Now, coming to the class 1 drug, class 1A drug, they basically blocks the sodium channel in the open state. Now, what happens due to the blockade of sodium channel, cardiac action potential A phase 0 is responsible by the opening of sodium channel. Now, when the sodium channel is blocked, the rate of phase 0 depolarization is decreased. So, the conduction is decreased, conduction of impulse is decreased. Now, the action of class 1A drug is moderate in the sodium channel blockade. So, there is moderate decrease in the slope of the phase 0 depolarization. Again, they also block the potassium channels and hence the cardiac action potential is increased. So, this is the action of basically class 1A drug. So, subclass 1A drug, they basically blocks the open state sodium channel and which also moderately delay this channel recovery. The channel recovery time is 1 to 10 seconds. They are responsible for the blockade of triggered arrhythmias and they abolish re-entry. Now, coming to the drugs within the class 1A, that include Quinidine, Procainamide and disopyramide. So, as it is included in class 1A drug, it blocks sodium channel in open state and hence it is decreasing the rate of phase 0 depolarization and it is increasing the action potential duration. Again, other than sodium channel blocking property, it has also got other properties that include antivagal property, number 1, number 2, alpha receptor blocking property, and lastly it has got direct cardiodepressant action. So, 4 actions are there. Now, so it is prolonging basically action potential duration. The other effects are fall in blood pressure. Fall in blood pressure cano, number 1 thing, alpha receptor blocking property causing vasodilation, and number 2, direct action, direct cardiac depressant action. Now, quinidine is related to quinine. It is derived, it is a dextroisomer of the quinine, which is an anti-malarial drug derived from the plant cinchona plant. Now, like quinine, on its use, it can show synchronism. It is an adverse effect with the use of quinine and quinidine that include ringing in ears, vertigo, deafness, visual disturbances and mental changes. Now, like quinine, it has got anti-malarial action. Uses, it can be used in many atrial and ventricular arrhythmias. Its use has been declined because of many adverse effects, including that of torsades pointis. Coming to the next drug, Procainamide. Now, Procainamide is similar to that of quinidine. The difference are, number 1, it has got antivagal action is absent. It is not an alpha blocker, so hypotension is less compared to that of quinidine. It causes less marked depression of contractility and AV conduction, so less direct cardiodepressant action. It is less effective in suppressing ectopic automaticity. Now, this Procainamide is metabolized by acetylation and the product N-acetyl procainamide has got no sodium channel blocking property, but they block the potassium channels. Now these enzymes CYP2D6, they show genetic polymorphism, and hence there are slow and fast acetylators of procainamide. Procainamide is occasionally used to terminate monomorphic VT and some supraventricular arrhythmias. Coming to the next drug, disopyramide. Disopyramide, its action is same as that of quinidine, but it has got additional anticholinergic property and antivagal property, but it has got no alpha adrenergic blocking action. Now contraindications are sick sinus, cardiac failure and prostatic hypertrophy. Why prostatic hypertrophy? Because of anticholinergic property linked with disopyramide. It is a second line drug for the prevention of recurrence of ventricular arrhythmias. Now coming to the subclass 1B, these were about the class 1A. Now subclass 1B, they also block the sodium channels as the sodium channel blockers, but they block the sodium channel in the inactivated state. Now inactivated state sodium channel kokon beshi thakbe? When the cell is partially depolarized or when the action potential duration is longer. So its action is more prominent in the cardiac cell where it is partially depolarized, like in case of ischemia, or where the action potential duration is longer. Now this class 1 this class 1B drug, they basically decrease the slope of phase 0 very minimally. As the channel recovery time is very fast, less than 1 second, and it basically also decrease the action potential duration, unlike that of class 1A drug. So these drugs block sodium channels more in the inactivated state than in open state, but they do not delay recovery, channel recovery. They do not depress AV conduction or prolong action potential duration ERP and QT, unlike that of class 1A drug. Now among the class 1A drugs, it includes Lignocaine, very commonly used anti-arrhythmics, and it includes mexilatine. Now coming to the Lignocaine, Lignocaine as we know is a local anesthetic and it is also used as an anti-arrhythmic drugs. Now it is a popular anti-arrhythmic drug. It is relatively selective for partially depolarized cells and those with longer APD, already discussed. The most prominent action is suppression of automaticity in ectopic foci. Now this Lignocaine, they undergo very high first pass metabolism. So drug is not taken orally, it has to be used parenterally. The action is short, 10 to 20 minutes, basically action of an IV bolus is short 10 to 20 minutes. Why? Because of rapid redistribution. Now hence, because of as the drug shows rapid redistribution, it has got distribution T half and elimination T half. Distribution T half is around 8 minutes and elimination half life is around 2 hours. Now its metabolism is hepatic blood flow dependent and hence prolonged in congestive heart failure, and Propranolol, it reduces the hepatic blood flow and hence prolongs the half life of Lidocaine. Now the side effect of Lidocaine is, the most important side effect is neurological. It can cause drowsiness, nausea, paresthesia, blurred vision, and definitely seizure. Fits can be seen. It is the least cardiotoxic anti-arrhythmic. They are mainly used for suppressing ventricular arrhythmias. So they are used to suppress ventricular tachycardias and prevent ventricular fibrillation. It is a good drug in emergency setting. Why? Because of fast onset of action, and its dose and its action can be easily titratable. For example, arrhythmia following acute MI or during cardiac surgery. It also suppresses VT due to digitalis toxicity. Now, subclass 1C. Subclass 1C, like that of class 1A, it blocks the sodium channel in the open state, and the channel recovery time is the longest, more than 10 seconds. So, it decreases the rate of phase 0 depolarization most compared to other class 1 drugs, but the effect on the action potential duration is minimal. It can either increase the action potential duration or decrease the action potential duration. Now, these are the most potent sodium channel blockers with more prominent action on the open state and the longest recovery time. They markedly delay conduction, prolong PR interval, broaden QRS complex, and they have got variable effect on action potential duration. And this class of drug have got very high arrhythmic potential, pro-arrhythmic potential when administered chronically, and sudden death have occurred. So, it should be always used in the in-house setting, in-hospital setting. Now, coming to the first drug, Propafenone, class 1C drug. Its action is more prominent on the Purkinje system as well as accessory pathway conduction. It prolongs action potential duration and has got beta adrenergic blocking property. As it has got beta adrenergic blocking property, it can precipitate congestive heart failure and bronchospasm. So, it should be avoided in asthmatic patient. Now, this drug is metabolized by CYP2D6, which again shows genetic polymorphism. So, they are slow or extensive or poor metabolizers of propafenone. Now, this can worsen congestive heart failure, already discussed, asthma, and increase the risk of sudden death. They are used for prophylaxis and treatment of ventricular arrhythmias, re-entrant tachycardia, and to maintain sinus rhythm in atrial fibrillation. Hasar kichu ache re? Is there something to laugh or to discuss? It is used for prophylaxis and treatment of ventricular arrhythmias, re-entrant tachycardias, and to maintain sinus rhythm in atrial fibrillation. However, in a patient of atrial fibrillation, it can paradoxically increase the heart rate by slowing atrial rate and allowing 1:1 AV transmission. Coming to these are all about the class 1 drug. Coming to the class 2 drug. Class 1 drugs we are sodium channel blockers. Class 2 basically are beta 1 adrenergic blockers. Can you give me some example of beta 1 adrenergic blockers? Already discussed in the autonomic nervous system. Example of beta 1 adrenergic blockers. তোমাদের ফার্স্ট সেমিস্টার পরীক্ষা তো হয়েছে, don't know the name. That include propranolol, atenolol, metoprolol, esmolol. These are the drugs that are used in arrhythmia here. Now, so they basically suppress adrenergically mediated ectopic activity. Beta blocker से ऐसे नोड ऊपर एक की एक्शन आसे, हाँ, decrease the heart rate. AV node AV node কি করবে? এগুলো বেসিক জিনিস, হ্যাঁ, decrease conduction and increase the effective refractory period. So, prolong the PR interval. These are all actions of the beta blockers here, class 2 drugs. Most commonly selected beta blocker is the propranolol. It is a non-selective prototype beta blocker. Now, anti-arrhythmic action is exerted primarily because of cardiac adrenergic blockade. There is marked decrease in the slope of phase 4 depolarization and automaticity in SA node, Purkinje fibers, and other ectopic foci. It also prolongs the effective refractory period of AV node because of anti-adrenergic action. Now, prolongation of PR interval already said. They are used for inappropriate sinus tachycardia. They are used to terminate paroxysmal supraventricular tachycardia, but are less effective than adenosine and verapamil. Okay. Drug of choice in paroxysmal supraventricular tachycardia, it's adenosine. আমরা আসবো এটাতে। Coming to the next drug, Sotalol. Sotalol, they are non-selective beta blocker. Additionally, and the more important action is they also blocks the potassium channels, delayed rectifier potassium channels, and thus causing prolongation of phase 3 and prolongs the action potential duration. Now, this potassium channel blocking property is associated with class 3 anti-arrhythmic drugs. So, Sotalol is basically having both class 2 anti-arrhythmic property and class 3 anti-arrhythmic property. They are blocking beta 1 receptors, they also block the potassium channels. So, it is a non-selective beta blocker having prominent class 3 action. It delays AV conduction and prolongs its ERP like that of other beta blockers. Sotalol is effective in polymorphic VT, ventricular tachycardia, some WPW arrhythmias, and for maintaining sinus rhythm in atrial flutter fibrillation. It is contraindicated in patients with long QT syndrome, long QT interval. Why? Because it is prolonging the action potential duration. Coming to Esmolol. Esmolol, the advantage is it has got very fast onset of action and very short onset of action, very short action. So, it is used in emergency setting because its action can easily be titrated. It is used to terminate supraventricular tachycardia and mainly used for arrhythmias associated with anesthesia, where rapidly developing beta adrenergic blockade is desired. Coming to the class 3 antiarrhythmics, as already said, class 1 was sodium channel blockers, class 2 was beta blockers, class 3 are potassium channel blockers. They basically blocks the potassium channels and thus their action, basically they cause prolongation of action potential duration and effective refractory period. So, the characteristic of this class is prolongation of repolarization, that is phase 3. Action potential is widened and ERP is increased. The tissue remains refractory even after full repolarization. Re-entrant arrhythmias are terminated. Can you give me an example of re-entrant arrhythmia? Re-entrant arrhythmia কোন এক্সাম্পল হবে? আমরা একটু আগে পড়েছিলাম রি-এন্ট্রি মেকানিজম দিয়ে কি এক্সপ্লেন করা যায় কোন অ্যারিথমিয়াটা? WPW syndrome, Wolff-Parkinson-White syndrome. Now coming to the first drug, Amiodarone in the class 3. Now Amiodarone, it is number 1, they are highly lipophilic. As they are highly lipophilic, they have got wide volume of distribution. So their action of their duration of action is prolonged. It's around 3 to 8 weeks because they accumulate in the fat and in the adipose tissue and in the muscles. Number 2, they are iodine containing. As they are iodine containing, long term use, they basically affect the thyroid gland and prevent the peripheral conversion of T4 to T3 and also blocks the thyroid action of the thyroid receptors. Hence, they can cause goiter, they can cause hypothyroidism, they can cause hyperthyroidism. Hyperthyroidism is rare, more common is hypothyroidism. So, they are iodine containing, highly lipophilic, long acting anti-arrhythmic drugs. Number 2, they are multi-channel blockers. They not only blocks the potassium channels, they also block the sodium channels like Lidocaine. So, class 1B type of action. They also partially block the myocardial calcium channels and they have got action as class 2 drug also, non-comparative beta adrenergic blocking property. So, it prolongs the action potential duration and QT interval by blocking the potassium channels, by blocking the sodium channel like Lidocaine. It suppresses the conduction in cells that are partially depolarized or having prolonged action potential duration and they have got calcium channel blocking property, beta blocking property and they alters thyroid function. Now, conduction is slowed, ectopic automaticity is markedly depressed, but that of SA node is only slightly affected. As it has got wide volume of distribution because of high lipophilicity, it accumulates in muscle and fat from which it is slowly released and then metabolized in liver mainly by CYP3A4. Half-life 3 to 8 weeks. They are effective in a wide range of ventricular and supraventricular arrhythmias to control including PSVT, and in case of nodal and ventricular tachycardias, atrial flutter fibrillation. Resistant VT and recurrent VF are the most important indication. They are also used to maintain sinus rhythm in patients of AF and atrial flutter. When other drugs have failed, rapid termination of ventricular and supraventricular arrhythmias can be done by use of intravenous amiodarone. Now, long duration of action makes it suitable for chronic prophylactic therapy. They even reduce the sudden cardiac death, and it's one of the commonly used anti-arrhythmic. Now, adverse effects are many with the amiodarone. Number one, it can cause fall in blood pressure, bradycardia and myocardial depression when given intravenously or on chronic oral use. Nausea, GI upset may occur due to oral medication. Now, important side effect is pulmonary alveolitis and pulmonary fibrosis on long-term use, but can be minimized by using the dose not more than 200 milligram. Others are corneal microdeposits, skin decoloration, transaminitis are rare, hepatotoxicity are rare but can be there. Thyroid dysfunction, it can cause goiter, hypothyroidism or rarely hyperthyroidism. Now coming to dronedarone. Now dronedarone is similar to that of amiodarone. The differences are, number one, it is less lipophilic. So less lipophilic, so lower or lower duration of action compared to amiodarone. Number two, it does not contain iodine. So it has got no effect on the thyroid function. But the problem is it is less effective than compared to the amiodarone. Coming to the class 4 drugs. Class 4 drugs are basically calcium channel blockers. Class 1 টা কোন চ্যানেল কে ব্লক করে বল ক্লাস 1 কোন চ্যানেল কে ব্লক করে কে বলবে class 1 are which channel blockers sodium channel blockers. Class 2 bolo beta blockers, they are blocking basically beta 1 receptors. Class 3 from the back side, class 3 কোন চ্যানেল কে ব্লক করে class 3 potassium channel के block करे and class 4 calcium channel blockers. अच्छा calcium channel blockers की नाम जानो name of calcium channel blockers, name of calcium channel blockers जोरे बोलो Verapamil R basically we divide the calcium channel blockers into two groups, dihydropyridine calcium channel blockers and non-dihydropyridine calcium channel blockers. Dihydropyridine calcium channel blockers, their action is more prominent on the peripheral vasculature. They include amlodipine, felodipine and others are there. And the non-dihydropyridine calcium channel blockers, their action is more prominent on the heart. They have got direct cardiodepressant action. They include Verapamil and Diltiazem. These non-dihydropyridine calcium channel blockers are used as anti-arrhythmic drugs. They include Verapamil and Diltiazem. So, class 4 drugs, they inhibit calcium mediated slow channel inward current. Now coming to the Verapamil, it blocks L-type calcium channels and delays their recovery. The basic action of Verapamil is to depress calcium mediated depolarization. As their action is in the calcium channels, they decrease the rate of phase 0 depolarization in the conducting cells. So they suppress automaticity and re-entry dependent on the slow channel response. Phase 4 depolarization in SA node is also reduced. Delayed after depolarizations in Purkinje fibers are dampened. The most consistent action of Verapamil is on the AV node. They slow the conduction and increase the effective refractory period, causing basic prolongation of PR. They have got negative inotropic action as well. Now, use of Verapamil, number 1, for termination of the PSVT and preventing its recurrence. Drug of choice of PSVT, paroxysmal supraventricular tachycardia, drug of choice কি আছে একটু আগে বলেছিলাম, it's adenosine, okay, but Verapamil is also effective for terminating attacks of PSVT and preventing its recurrence, to control ventricular rate in AF and atrial flutter. It does not bring the patient to sinus rhythm, it controls the ventricular rate there. Re-entrant supraventricular and nodal arrhythmias. Verapamil has got poor efficacy in ventricular arrhythmias. They are only used for supraventricular arrhythmias. It is not recommended for digitalis toxicity and it is contraindicated in partial heart block and sick sinus. Coming to the next, Diltiazem. Diltiazem action is similar to that of Verapamil. Action is similar to that of Verapamil, but it has got lesser cardiodepressant action. So it can be used in patients even of mild to moderate heart failure. For rapid control of ventricular rate in atrial flutter or fibrillation, IV Diltiazem is preferred over Verapamil because its dose can be easily titrated and it causes less hypotension or myocardial depression. Now coming to the drugs used in PSVT, paroxysmal supraventricular tachycardia. The treatment of paroxysmal supraventricular tachycardia, it can be non-pharmacological, it can be pharmacological. When a patient arrives of PSVT, we see whether the patient is hemodynamically compromised or hemodynamically not compromised. Jodi hemodynamic compromise na thake, we go for basically the non-pharmacological measures first, that include carotid sinus massage or reflex vagal stimulation, splashing ice cold water on face, hyperreflection of the neck. When the non-pharmacological measures are not effective, we go for pharmacological treatment and the drug of choice is adenosine, while class 4 anti-arrhythmic drugs can be used and esmolol can be used. When the patient of PSVT has been treated, to maintain the sinus rhythm, oral therapy with Verapamil, Diltiazem or Propranolol can be used, or they can be combined with digoxin also. Adenosine. Adenosine, as the name suggests, basically they act on the A1 type of adenosine receptors, causing activation of acetylcholine sensitive potassium channels. And thus, in action on the SA node, they cause bradycardia. In the AV node, they cause slowing of conduction. And in the atrium, they cause reduced excitability. Now, this adenosine, they terminate within 30 seconds, more than 90% episodes of PSVT. And in PSVT, the drug of choice is adenosine. It has got very short half-life, around 10 seconds, because of rapid redistribution in the endothelial cells and the RBC. Now, advantage of adenosine in treatment of PSVT, number 1, it is equally effective or rather more effective compared to Verapamil and other drugs. Action lasts less than 1 minute because of rapid redistribution. So, even the fatal adverse effect like cardiac arrest is transient. No hemodynamic deterioration is seen. Basically, as the drug is very short lasting, even the hypotension, congestive heart failure are transient and hence no hemodynamic deterioration are seen, where Verapamil is contraindicated. They are safe in wide QRS tachycardia and they are effective in patients even not responding to the Verapamil. Now, adenosine produces transient dyspnea, chest pain, fall in BP and flushing in 30 to 60% of the patients. Even a transient cardiac arrest can occur. Ventricular standstill for few seconds or VF occur in some patients. Bronchospasm can be precipitated, so this drug is contraindicated in asthma, where Verapamil is the drug of choice. Now, it is not suitable for prophylaxis in recurrent cases. Now, drugs for AV block, definitely in the AV block, the treatment of choice is pacing with an implanted cardiac pacemaker. Drugs can be used transiently or in acute setting. when AV block is, atropine can be used in AV block due to vagal overactivity. And among the sympathomimetics, isoprenaline can be used. These drugs may overcome the partial heart block by facilitating AV conduction and shortening ERP. They may also be used in complete heart block to maintain a sufficient ventricular rhythm transiently till we go for permanent pacemaker. Now, some other anti-arrhythmic drugs are also used like magnesium sulfate and digoxin. Digoxin kintu heart failure para hoise. I am not going with that. Magnesium sulfate, the mechanism of action is unknown, but it has got action in torsades de pointes, which is a basically life-threatening ventricular arrhythmia, and it can also be used for the treatment of the eclampsia and pre-eclampsia. That's all.